Good evening. Welcome to the AO North America Trauma Journal Club. Tonight's focus is going to be on distal humerus fractures. My name is John Morlato. I'm from the University of Mississippi Medical Center in Jackson, Mississippi. And tonight we have a great lineup of speakers for you. Joining me as moderators is Luke Harmer from Atrium Health Cabarrus Hospital in North Carolina. We've got Adrian Huang from St. Paul's Hospital in the University of British Columbia in Vancouver. And we've got Will Pennell from California Hospital in Los Angeles. We also are welcoming our invited authors. We've got Dr. Brad Henley from Harborview Medical Center. We've got Dr. Jesse Jupiter from Mass General. We've got Jason Strelzo from the University of Chicago. And we've got Dr. Sean O'Driscoll from the Mayo Clinic. And thank you very much to everyone for joining us tonight. There is a few housekeeping issues before we get started. These are our disclosures for the faculty tonight. This is our content validation statement. So tonight we're going to hear about 4 different articles, and at the end of our session, our goal is to learn from the early experiences of fixing these challenging fractures and learn about different technical aspects and the approach to approaches and fixation strategies. We'll also hear about total elbow arthroplasty in the setting of elderly distal humerus fractures. A few Zoom etiquette things. All of your microphones will be muted. However, you can at any time ask questions to the question and answer box. These will either be answered directly by the authors or be held until the discussion. This is our agenda. We're going to go through these first 2 articles from Dr. Henley and Dr. O'Driscoll, and then we're going to have a discussion session followed by the last 2 videos and then another discussion. Now, again, at the end, don't forget to fill out the questionnaire that's going to pop up on your screens. And without further ado, we're going to get started with Dr. Henley's article, Operative Management of Intra-Articular Fractures of the Distal Humerus. It's my pleasure to be talking with Dr. Brad Henley. He's from the University of Washington at Harborview Medical Center. He's currently clinically retired, but still busy with the faculty there. We're talking about his article from 1987, Operative Management of Intra-Articular Fractures of the Distal Humerus. Thank you for being with us, Dr. Henley. Now, I guess I really just want to start with, and this was a 5-year experience at Parkland Hospital in Dallas in the late 70s, early 80s. Can you discuss how this paper came about and what the impetus was for writing the paper?
Sure. Let me go back to sort of UT Southwestern, Parkland. Bert Mooney became the chair in the mid-80s, and prior to his arrival, most of the fractures, I think throughout the United States, but especially in Texas, were treated conservatively. He was aware of the AO and its movement towards stable anatomic reduction and fixation, and he had a vision of moving orthopedic education in that direction at Parkland. In the late 70s, he talked with Martin Algover and got a visiting professor to come join the faculty for 2 years. That was Bernd Cloudy. One of Bernd's disciples was Larry Bone, who's a co-author on the paper. At the time we did the paper, he was doing his 2nd residency with us, having graduated as a general surgeon from the University of Buffalo and being in practice, I think, for up to 7 years with his father. So based on Bert's vision, in 1979, they moved towards internal fixation. And this is about the time when I started my residency there. And it was during my residency that I saw these patients. I was interested in the surgery, which I thought was fairly unique, but I also saw the complications and felt that we could disseminate the information, what we'd learned throughout the 5 years, to others in the community. And, you know, as a resident, I basically saw the risks as well as the benefits and thought that this was important to share our knowledge and the evolution.
That's great. Now, in this paper, it seems like, as you mentioned, things sort of evolved throughout those years. One of the takeaway points was that to use heavier plates, especially with some of the more comminuted fractures. How did your techniques sort of evolve in those early years?
So the AO implants in the 70s were pretty early, and the initial supply was fairly limited. If you remember, half tubular plates with 4.5 screws were even used on both bone forearm fractures. And over the 70s, they evolved into more rigid plates, such as the DC plates, and then eventually the recon plates came out. But during the time of this study, at least early on, the main method of fixation was with third tubular plates, either on both columns, or if I recall, not all had that, usually 1/3 tubular plate on at least one column, and then either a lag screw or a positioning screw in the other column, or even K-wires. And we saw failures when the plates weren't stiff. The third tubular plates, you know, weren't rigid, and we started early range of motion because we felt that was a benefit, and one of the principles of the AO of stable fixation and early motion. We also found that the plates weren't long enough to neutralize the bending forces, and we had some supracondylar non-unions, even though the intercondylar fractures had healed. So essentially, early on, we were using less stable fixation, those being third tubular plates with or without, less stable on the contralateral column. And as we did this series and looked back, we found that you needed, for sure, more stiffer implants, and then gradually went to DC plates. And then as recon plates evolved, used those because they were used to contour to the bends of the columns. It should be noted that early on, the AO did not make both annealed and non-annealed recon plates. So they have different properties in terms of their stiffness, whether they're annealed or non-annealed. And you should be aware that those are both available, and you have to know which one you're using.
Right on. Now, you had 29 of 33 patients in this series have osteotomies. And again, another one of the take-home messages was that the tension band fixation provided or produced a high complication rate, and you recommended the cannulated screw fixation. Can you talk about sort of how that evolved, and then how fixation of osteotomies evolved throughout your career?
Yeah, certainly. I think of the osteotomies, 14 were fixed with K-wires and tension band wires, and that was a classic method of AO teaching. We found that it was difficult to impact the bent K-wires into the Electron because of the cortex being so thick. And in order to impact them, sometimes we drill a couple of small holes and countersink them into the cortex. But most of them were left proud, as you can see by the X-ray images in the article. They were just impacted as best they could through the triceps. Let's see, we found, when we looked at that series, a lot of the K-wires backed out, irrespective of how they were, quote, buried, or that the tension band wires and K-wires could fail. They either bent or broke, leading to non-unions or delayed unions. The other half, another 14, were fixed with 6.5 screws, I think because of the early failures we saw with the tension band wires. But even some of only one of those failed, and that was, I believe, with a short 6.5 screw. So we started to move to longer 6.5 screws that engage the metadiaphysis and not the shorter 6.5 screws. So there's really no instructions on the length of screws to use, or the length of K-wires, or whether the K-wires should be even put out through the anterior cortex, the ulna. And we didn't do that. They were just sent down the canal, and therefore didn't have a bicortical fixation. The other thing that evolved is, I think all of these osteotomies were done transversely to the long axis of the ulna. And what we found was that there was no really interdigitation, like in an olecranon fracture of the spicules of bone. And that smooth surface just didn't lend itself to stability. What has happened since that time is we talked with others. We moved to a Chevron osteotomy with the base of the chevron, in the electron on the apex, approximately into the metaphysis. And that gives both a rotational as well as bending stability. What we found with the transverse osteotomy in the 6.5 screws, because of the proximal bend of the ulna, if you inserted a long 6.5 screw, it's very stiff, and it tends to translate that osteotomy slightly and didn't give you the rigidity or the anatomical alignment that you would have liked, whereas the chevron positions that reduction well and maintains the stabilization. So other than changing the shape of the osteotomy, we've also now evolved to using plate fixation nearly 100% of the time, and we've looked at our case at Harborview, have essentially no non-unions. I mean, get rigid fixation with a lag screw from the apex of the plate into the anterior cortex, and what we call the home run screw down the medullary canal from also the apex of the ulna, with a couple of 2 or 3 screws in the metadiaphysis. So essentially, it's an evolution from less rigid fixation that was weaker and failed to some more rigid fixation, and now even to the most rigid fixation in plates. Irrespective, I mean, the Electron is subcutaneous, and some of these implants are symptomatic and have to be removed, but that's not routine.
Great. Well, thank you very much for sharing your article with us and your thoughts on that. It's much appreciated.
You're welcome. Thank you.
It's my pleasure to be.
So we'll move on to our next article. This is complex distal humeral fractures, internal fixation with a principle-based parallel plate technique. Luke Harmer and Dr. O'Driscoll.
Dr. O'Driscoll, thank you so much for joining us here this evening on this AO North America webinar.
Thank you, Luke.
It's really a privilege to have you part of this panel. So this paper back from 2007, Complex Distal Humerus Fractures, Internal Fixation with a Principle-Based Parallel Plate Technique. Can you take us back to before 2007, 15 to 20 years ago now? Tell us about intra-articular complex distal humerus fractures, and what was the state of the art back when you were starting to think about this question in this paper?
Yeah, sure, Luke. It's great. Thanks for the privilege of being here. When I would introduce this back then, and I think I'll just use the same way of introducing it right now, I would just ask orthopedic surgeons, if you had maybe an AOC3 fracture of the distal humerus, would you be distraught or really worried? And almost everybody would say, yes, I would be. What if you had maybe a lateral malleolus fracture of the ankle? Would you be distraught? And not many people would be. And I would ask, what's the difference? Well, the difference is that we knew how these turn out, and they did not always turn out well. In fact, they often turned out really badly. And so there was a problem. We thought we knew how to fix them, and we thought we had that understanding adequately as surgeons to do a good job of it. But we recognized that there was a problem, and the problems related to the fact that they didn't always heal. If they healed, they often ended up stiff, and the stiffness was often because we didn't trust them to not fall apart if we got them moving, and so we would protect them, immobilize them for a period of time, even after internal fixation. So these were very, very intimidating types of fractures to try to treat. And I think most people would say that it was a really, really difficult thing to do a good job of a badly fractured distal humerus.
That makes sense. So the paper that we have in front of us, most of us have had a chance to read it and see what you did, a case series of 34 fractures and 33 patients. So will you take us through the principles? The title of the paper is a principle-based parallel plate technique. What are those principles that you outlined in that paper, and how does this paper help us as orthopedic surgeons take better care of these, as you say, these scary kind of fractures that perhaps might have a bad outcome?
Yeah, thanks, Luke. And we called it a principle-based approach because we felt that the contribution here was essentially a communication of the principles that we believed would enable the improvement of the treatment of these fractures. We didn't propose to have the technical method that was the way they should be treated. We weren't trying to do that. It was, here's a principle, a set of principles on which we can approach the problem. So the first step was to identify the problem, which we just spoke about, the problem being non-union at the supracondylar level, typically at the supracondylar level, sometimes the intercondylar level, and failure of fixation. Or if those didn't happen, then the problem was stiffness, usually because of concern about either of those happening and therefore the resulting immobilization that was used. So having said that, that was a problem. We had to develop some principles by which we would understand how we might improve that on that problem. And the problem was due to inadequate fixation in the distal segment. So if we think about the shaft and the distal segment, which has often in these fractures multiple pieces to it, it was just not possible based on techniques at the time to get adequate fixation to stabilize that segment of the distal humerus to the shaft the way we would normally fix fractures with rigid internal fixation according to standard, well understood AO principles, to which I was a strong adherent. So we had the problem, we identified two principles that could be satisfied potentially and improve that. The first would be that we would have to optimize or maximize, you could use either word maybe, fixation in the distal fragment itself. And the second would be that any fixation in the distal fragment should, if possible, contribute to stability at the supracondylar level, meaning if you're going to put hardware into the distal segment, try to make that hardware contribute to both optimizing fixation distally and stabilizing the distal part to the shaft. So those were the two principles that we set out to try to satisfy. And from those two principles, we derived a list of technical objectives, which, if fulfilled, should result in the satisfaction of those two principles. Initially, and in this paper, there were 8. We came to realize that one of them really probably wasn't necessary. We dropped it to 7. And so there are 5 that are concerning the screws that go into the distal segment, and 2 that concern the relationship involving the plates that join the distal segment to the shaft. And so those objectives are things like every screw going into the distal segment should go through a plate. That satisfies both principles, number 1 and number 2. Screws that go through a plate should go all the way across and into another fragment that's stabilized by a plate. So they become fixed angled stabilized screws. Before we had such a thing as fixed angle screws. And we went on to develop a number of other, or to list a number of other. And a key one was the one in which we want to link the two columns together and create something that from an engineering or architectural perspective has structural stability. So the concept of an arch, and without the arch, without the keystone in an arch is not stable. It's not stable until they're linked, all the parts are linked together. But in fact, we want to go way past an arch alone. We want to actually structurally link the two columns together and all the pieces in between the shaft on one side, the distal segment, and back to the shaft on the other.
Can you talk to us about how things have changed since 2007, and then specifically, has the advent of locking implants at all changed your principles or changed your management of these injuries?
Yeah, that's a great question, Luke. Once locking technology came out with the LIS plate for the distal femur, I recognized right away it was going to play a role in the distal humerus for sure. But let me start out by saying that locking plate technology is one of the least important things about all this. And I would also say that I don't think that a skilled surgeon who understands these principles and has had some practice with them, I don't think that such a surgeon very often, maybe rarely even, needs locking plates. I'm perfectly comfortable. When we had only one set of locking plates here, I always made sure that my partners at the other hospital had it available to them, and I would just use regular non-locking plates unless we could bring the set over, in which case I would use the locking plates. So locking plates have many advantages, and I don't need to espouse what those are. Everybody here, I think, knows what the advantages are. So they somewhat diminish some of the requirements for, shall we say, precise satisfaction of all these technical objectives. So you might get a little bit of leeway on some of them. But when the fractures are really, really, really complex, locking plates are not going to solve the problem whatsoever. So yes, fixed angle screws are good, but the best way to make a fixed angle screw is not to lock it in the plate, but to lock it at the other end. The way you convert a diving board to a diving platform, a diving board, doesn't matter how strong you make it, it's still going to be a diving board. And so the way you convert it to a diving platform is you put something at the other end. And that's why objective number 2 is that every screw that goes through a plate in the distal fragment should be anchored in a fragment on the other side that's fixed in place by a plate. So you convert your screw to a fixed angle screw. It's not locked in the plate, but it is a fixed angle screw. And then when you do objective number 5, which is to interdigitate and lock them together, they all become locked together. So is it a locking screw or is it a locking system? Or is it a system? Yeah, is it a system of locking screws or is a locking system of screws? And a locking system of screws is structurally, from an engineering perspective, far more stable than just trying to lock the screw in the plate.
That makes a lot of sense. That analogy makes a lot of sense. And then tell me about the posterior lateral plate versus the lateral plate. That's one of the things that I think has come from this paper, that this idea of putting a lateral plate on the lateral column instead of the posterior aspect of the lateral column. Are there any downsides to that as you've worked with this technique? Is there any disadvantage of moving the plate over laterally, perhaps putting it over the lateral ulnar collateral ligament? Is that give patients stiffness from the position of that plate? Is there any disadvantage of this change in technique that you?
Right. Yeah, good questions, really good questions. Several questions in there. So trapping of the LCL. The LCL is trapped for one of 2 reasons. Either the plate design did not take that into consideration and multiple plate designs failed to take that into consideration. So when I would see the plate first time I saw it, I thought, oh yeah, well, that's going to trap. Maybe not just trap, maybe even necrose the origin of the tendon and or ligament, but it will trap the tendon and or ligament. So plate design is important. You look at an x-ray of the humerus, and as you get to the lateral epicondyle, the humerus then goes inwards to the capitellum, but the body does not go inwards. The body continues outwards slightly. And the plate coming off the lateral epicondyle at that point should leave the bone and be either stopped there or be off the bone. And if it's off the bone, the screw will trap the soft tissues, but that screw should be taken out some period, 6 or 8 or 12 weeks later, when you think stability is adequate now that you don't need that screw anymore. So trapping the soft tissues occurs by plate design or by planning that it's just an inadvertent complication required to get adequate fixation. And that's for the severely comminuted low distal humerus fractures with coronal shear. And then you bring the plate down far enough onto the side of the capitellum that you get additional purchase in bone and stability by the plate. And you know that's going to trap it. And that becomes a 2-stage procedure where you know you're going to come back and do a contracture release later with hardware removal.
As we all know, the bone is the fun part for us as orthopedic trauma surgeons, especially, but it's surrounded by a soft tissue envelope. And many of us who treat these injuries have had complications related to wound healing, the flaps we raise to fix these fractures. Can you talk to me about soft tissue management in these? You alluded to flaps on the lateral side not being larger to get around to the lateral side of the lateral column. But what have you learned? What can you teach us about soft tissue management?
Yeah. That's. I think that's probably the single biggest thing I've learned since I published this paper, or we published this paper. Back then, I did not really comprehend fully the impact of this relationship that you've just raised. And for example, in that paper, we had 2 patients who were reoperated for wound healing complications, one of which had a deep infection. But wound healing problems are unquestionably related to not just the magnitude of the soft tissue injury that occurred, but the flaps that are raised. And so to the extent that you can decrease the flaps that are raised, that's going to, in the end, have an impact on the potential complications related to soft tissue and wound healing. So on the medial side, for example, the flap is big if we go all the way around and transpose the ulnar nerve. If we don't transpose the nerve, the flap can be substantially less. I don't have an answer for whether the nerve should or should not be transposed. There's still many reasons both ways to think that it should or should not. But having said that, with a distal humerus fracture, we're forced to raise some flaps unless we can develop a technique. And it would be very worthwhile if we can, where we do not have to raise those flaps. For example, if we can perfect a technique where we can go in medially and laterally and raise no flaps at all, or do some of this somehow or other percutaneously, if that ever becomes technically possible for us, that would be an enormous step forward, because I think it would greatly diminish it. But in the meantime, the post-op management really matters. And that's the part I did not register adequately back then. So we knew that we should get these moving. We did. We even used CPM in some of these patients. I think that keeping the wounds still, keeping the arm still with the elbow extended and a soft pad on the back, so a very thick Robert Jones type bandage with plaster in the front that keeps the elbow straight, dramatically better than keeping the elbow at 90 degrees. I think if a trauma surgeon today took only one thing away, I would say familiarize yourself with immobilizing the elbow and extension with plaster on the front and soft wrap everywhere else, of course, rather than putting it 90 degrees. And that has a dramatic impact, I think, on the healing of the soft tissues. And the second is that I don't move them before 5 days. And I'm not sure whether it should be 5 or 7 or 10 or even a little bit longer than that. If there's a real wound concern, I don't move them until I'm fairly sure the wound is okay. But somewhere longer than 3 days and maybe even longer than 5 days would turn out to be much better than shorter in terms of wound healing problems.
Outstanding. Well, Dr. O'Driscoll, I think we'll stop there for tonight, but that's outstanding. Thank you so much. And we look forward to seeing some questions in the chat later on. So thank you very much.
Thanks very much, Luke. Really appreciate it.
Okay, what we'll do next is
Dr. O'Driscoll.
We'll talk about, I'll hand this over to Dr. Harmer for a little bit of discussion regarding the first 2 articles.
So it's really a privilege to hear Dr. Hanley and Dr. O'Driscoll talk about the early experience as they've worked out their techniques for figuring out these fractures. And as time has gone by, we've learned some things about this. So let me start by asking Dr. Hanley. We heard Dr. O'Driscoll talk about the change in technology, and in your video there, you spoke about the change in the implant, starting with 1/2 tubular plates and moving towards the various recon plates and such. Let me ask your comments on locking plate technology and how that has changed your practice in the management of these injuries.
No, I tend to agree with Sean. I don't think it's necessary as long as you can obtain a stable construct. And it's, not going to hurt, but it's expensive. And if you're looking at the cost effectiveness of these implants, you usually don't need them. I think they're a little bit more helpful if you have a lot of intercondylar comminution. and also perhaps when you have dissociation from the medial epicondyle, from the medial condyle or trochlea.
And as we're talking about fixation, I'll put forward a question from the chat to Dr. O'Driscoll. We'll start. Sometimes it's convenient operatively to lag the articular pieces together prior to managing the metaphyseal reduction. Is there a role for using an independent articular lag screw prior to following the rest of your principles of every plate goes through every screw goes through a plate, forgive me, as we start to fix these fractures? An independent lag screw, does that hurt, or could that augment the rest of your principles?
Yeah, Luke, thanks. That's a really good question, because if you apply a very basic standard principles of fracture fixation, if you get interfragmentary compression, and then you can neutralize that with a plate or plates, and the distal humerus would be 2 plates, then you've accomplished the goal. The problem is that in these fractures, very often, that's a difficult thing to accomplish. So let's assume that this is anything other than a simple fracture, 2 pieces of condyles with a single shaft in a young person with strong, healthy bone. You can compress those and neutralize them probably however you want, and it'll probably do okay. But let's say that it's not that. It's got some comminution, or the bone is soft, or anything else. Now it becomes important that you accomplish those 2 principles. And if you put the screw across the condyles to begin with, you probably are interfering with placement of a future screw, a future meaning a future in the next hour or 2, into that distal segment. And that, therefore, will compromise ultimately the fixation you get in the distal fragment, but more importantly, the linking of that to the supracondylar level, or in other words, it will interfere with contributing to supracondylar stability later. So I strongly recommend learning how to hold off placing that screw that you want. You can place it later, but place it through a plate. And if you're all finished, you've got the plates on, everything stabilized, screws can go into the distal segment then and build onto the hardware. But you should try to hold off until you have the plates in place.
I agree with you, Sean. One of the things I've found is for the 3-5 screw, unless you have a very large stature individual, that's going to take up the central portion. Usually can get a 2-7 and a 2-4 perhaps through a plate, but I agree with you. Use a provisional fixation, use K-wires, which can be extracted, and save your screw fixation for your plate.
Yeah.
So it's so interesting how the discussion on these fractures so often turns into discussion about the fixation, stable fixation being one of our principles. We sometimes ignore the anatomic reduction portion of this. So for any of the panelists, would you give us 1 or 2 tips or tricks about the vital steps in the reduction part of this? And that could be anything from approach right through how do you manage getting an anatomic reduction, both of the articular surface, but as evidenced in Dr. Henley's paper, the metaphyseal reduction can often be a challenge, and non-union at the metaphysis is a big problem in these fractures as well. So
Sean, let me start. Generally we use a paratricipital approach through a posterior midline incision. And after doing that approach and mobilizing the triceps and identifying obviously the ulnar nerve and the radial nerve, we perform an arthrotomy to visualize the joint surface. That's done, the visualization is done more easily with a headlight and maybe a small tenaculum or bone reduction forceps on the Electron without doing an Electron osteotomy. And you can distract the joint, evacuate the hematoma, irrigate it, and get a pretty good view from one side and the other of the Electron as the fracture. The most difficult part in the reduction is if you have is the separation between the capitellum and the trochlea, or a trochlear split, and trying to reduce the rotational alignment of those 2 components. If they're attached to the epicondyles, no problem. But if one is dissociated or the second is dissociated, that makes it more difficult. And it's only obviously in simple C1s, we don't do an osteotomy. But if you can't get that reduction by manipulating those fragments, either with small dental picks, then we'll go ahead and do an osteotomy as sort of I described. And then it's obviously vista vision. You can see everything. But the key thing, I think, is the reductions aren't difficult. Most of these fractures click together perfectly once you're able to reduce that rotatory difference. And also they seem to click together in the metaphysis. We oftentimes, for metaphyseal comminution, will use some micro or mini plates to provisionally stabilize fragments unicortically, saving the medullary canals of the columns for the longer screws. So I'll stop there and let Sean expand if you'd like to do so.
Yeah, I would agree. And I think probably we all feel that if there is any additional measure of difficulty that you're experiencing, it makes perfect sense to get the exposure. And don't struggle with a limited exposure. That's not necessarily a good idea. And a couple of things I found have been, one is to try to push the fragments against the coronoid and the radial head. I actually do the supine, which is not easy if you don't have plenty of help. But if you have plenty of help to hold the forearm in place, then you can actually use the weight of the forearm coming back against you to push the pieces up against the coronoid and the radial head. And that corrects this rotational displacement that you just described. And then you fire a temporary K-wire across to just hold it there. And the second thing is that when it's comminuted at the level of the articular surface, you want to try to convert it into something that looks like a two-part articular surface. Build up the pieces one on the other, or if there's a single piece in between, you can trap that piece. And I'll make one clarification that the posterior comminuted pieces, I don't put on until the end, when everything's all fixed. You can build those on at the very end. And if they're on the back table because they're so comminuted, then quite frankly, you can see through that gap and even help with the alignment there.
While you were speaking, Sean, I thought of a couple other hints. You can put small joysticks in the fragments to help rotation, or a small bone reduction clamp on the epicondyle to help with rotation. If you're doing this prone, then by having someone elevate or lift up the forearm to take the dependent weight off it and the flexion, that really assists more with the reduction of the articular component to the metadiaphysis or diaphysis. And lastly, a large bone reduction clamp from the center of the trochlea, making sure you don't have the external portion of the trochlea, protecting the ulnar nerve to the capitellum or epicondyle allows good control and compression once you've obtained your reduction. It continues to stabilize it. And lastly, as you said, I think building from one to the other. In other words, when you have intercondylar comminution, gradually assembling the pieces and advancing K-wires. So placing a provisional K-wire in the first component, reducing the second one and advancing that a little further into that component and adding additional pieces while you advance the K-wires leads to success.
Awesome. Thanks for that discussion. I think that's super helpful for us who are struggling with these fractures. A number of the participants in the chat are asking about the coronal shear fracture, and then specifically with regards to parallel plating. So I'll turn this to Dr. O'Driscoll to begin and then invite the others to chime in. But it seems to be counterintuitive to use parallel plating, which would be in some ways parallel to the fracture plane. So Dr. O'Driscoll, can you talk us through the fractures that have a coronal plane component, and how do your principles apply in that scenario?
Yeah, thanks, Luke. It is counterintuitive, and I hear people say that that's if you're ever going to really use 90-90, if you're in favor otherwise of sagittal plating, that's when you should do it. But in actual fact, I think it's probably the epitome of the most difficult fracture to fix in which you should use that. So, and I can pull up a couple of slides to show it if you like, but here's the key. The key is that you want two screws to go, this will be medial over here, and this will be lateral. You want two screws to go through into the coronal shear fragment. Those are long in the coronal shear fragment. Those screws go through a plate medially, and those screws are going to be locked in position by two screws also going through a plate from the lateral side. Now you have these locked together, and that coronal piece can't go up or down. All it can do is go forward, can't go backwards. It can only go forward. And that's locked in place by 1 or 2 screws that go from back to front, interdigitating with the others. So you get this 3-dimensional grid work of bone and metal all locked together as part of the very same principle-based approach that you use that we talked about in the paper. And a key part is to have a plate that comes down on the medial side under the epicondyle onto the side of the trochlea, because then that screw goes right straight across into the coronal shear fragment. The other one goes through the epicondyle down into it. And you might only put 1 screw from medial to lateral. That's probably okay, but I use 2. If you'd like me, I'm glad to pull up a slide sequence that shows
I just
that.
add that depending on the plane of that those coronal fragments, we also will bury countersink 2.0 or 2.4 millimeter screws in order to neutralize those shearing forces. So that's also available, and especially if you can't get your plates to capture them because of the fragment's orientation. There's one question here that wanted to add, that someone asked about. Intra-articular distal humerus fractures, do we prefer olecranon osteotomies and or triceps tongue splits? And we definitely prefer for osteotomies because we like rigid, stable fixation of the osteotomy with plates and lag screws and early motion. And we feel we can't do that reliably with the soft tissue repair.
That's great. I think what we'll do in the interest of time, Dr. O'Driscoll, at the end, if we have some time, we might come back to those slides because I think that would add quite a bit. But I want to move in. Let me share my screen one more time here. All right. So we're going to move on to Article 3 now. This is Dr. Jupiter's article, Electron Osteotomy for Exposure of Fractures and Non-Unions of the Distal Humerus.
Okay, so I'm here with Dr. Jupiter. We're going to talk about the paper on Electron Osteotomy for Exposure of Fractures and Non-Unions of the Distal Humerus. Dr. Jupiter, thanks for joining us. I think my first question I'd be curious to know is kind of what was going on at the time that you decided to come out with this paper. I've done a little bit of research on it. It's obviously prior to this, there's a lot of literature published on problems with doing an electron osteotomy and non-union after it. But what was kind of going on at the time that led you to do this study?
Yeah, that's you surmised that very well. The experience in the literature was somewhat negative regarding this technique. Because you are creating a fracture, it turns out that the actual fixation of the osteotomy was proving to have some problems for a number of people. This is a technique paper. In the era of randomized controlled trials, et cetera, we've lost sight sometimes of analyzing a technique, and if it's done thoroughly, it can provide information for the reader, for people. So I learned during my residency in the late 70s, this was about the only approach short of procedures for total elbow arthroplasty. And it became evident that there were specific pitfalls and pearls that made the osteotomy more predictable. And I can go through that with you if you'd like.
Yeah, I think that would be
per se.
great.
Yeah. In the first place, it is good to know where the ulnar nerve is when operating around the proximal ulna or the humerus. there's a lot of variation in how people deal with it in fractures, and the Canadian Combined Study Group looked at the ulnar nerve specifically and found more than a handful of people had ulnar nerve symptoms after surgery, regardless of what you did with the nerve. But most resolved over time, but it takes a long time. But I've always felt that not only knowing where the nerve is, but I like to mobilize it sufficiently as it goes into the two heads of the flexor carpi ulnaris and proximally up to the medial intermuscular septum. And this is where you see problems with the nerve when it doesn't do well. It either gets adherent in one of those two places. So I think it's worthwhile in most cases to do this, especially if patient has preoperatively symptoms. So this next thing is where to and how to do the osteotomy. You would like to do the osteotomy in the very center of the hyaline cartilage. And actually, many studies have looked at the anatomy of the olecranon sulcus. And believe it or not, there's robust cartilage on the coronoid, and there's robust cartilage in the olecranon tip, the very proximal olecranon, but not in the middle. In fact, many patients will have no cartilage there at all. So that's a good place to make the osteotomy. But how do you define that very well? Well, one way is to lift up a little bit of the anconeus off of the lateral side and take a look inside. And you'll be able to get a much better appreciation of that area of the center of the olecranon sulcus. So we'd like to do that in a way that we can be more confident that the majority of the osteotomy is done in that spot. So the next thing is, if you can put a sponge or tape or something from the lateral side to the medial side, that will help you to elevate up the olecranon. And when you're doing the osteotomy, avoid injuring the cartilage on the end of the humerus. That'll be your protection. I've always felt that creating the osteotomy in a, what people call a chevron manner has several advantages. They are that you can reposition the osteotomy and it has some inherent stability because it's not a transverse osteotomy with very little interdigitation of subchondral bone. And secondly, it gives you a broader interface that for healing. So that always made sense. And if you get an idea of creating the osteotomy with the distal tip of that chevron somewhere near the center of the olecranon sulcus, it will be very safe. And then traditionally, we were taught to use a very thin blade and cut in a power saw 2/3 of the way across, and then complete the osteotomy with a thin osteotome. And the rationale for that was that there would be some irregularity of the surface of the anterior surface that might help also for interdigitation. Okay, so we've done that, and then elevate from distal to proximally as much as needed for exposure. And the exposure, frankly, is the best exposure for more complex articular fractures that are distal to the olecranon sulcus. Those are very more difficult to gain visualization. When doing the osteotomy and elevating this olecranon up for non-unions, especially supracondylar non-unions, those patients have been moving through their non-union and not necessarily their joint. And so when you elevate it up, you have to be careful that you're not pulling off cartilage from the distal humerus.
Oh.
So that's the approach, okay? Then the problem is how to give you stable fixation. And that's really the method of treating olecranon fractures at the same level. The K-wires, if you aiming them slightly ulnarward and from the dorsal or inferior surface of the proximal ulna, and try to get into the anterior cortex of the ulna, distal to the osteotomy. And you better to place 2. It gives you simply rotational control.
Yeah.
And if you can do that, you want to control that with X-ray to make sure you're not headed toward the radial side, because there have been reported cases of people having problems with their forearm rotation because the tips of the K-wires are hitting the radius in rotation. And then you can bring back the, we brought back the olecranon into its original position, and by making a drill hole, maybe 2 centimeters distal to the olecranon osteotomy, and you take a pointed reduction clamp, that will help you in the stability of the reduction while you're placing the K-wires and then placing the tension band. The secret of the tension band is you have to have an adequate length of coverage to control the forces that want to pull it apart. And so if you look at the measuring the tip of the proximal ulna to the olecranon osteotomy, you need to be at least as distal to the osteotomy as that, and preferably more. So the main problems that people found in fixation were the K-wires would back out. The way to stop that is to bend the K-wires twice, so it has a 90 degree bend, and then hammer them into the proximal olecranon. They won't back out if that's the case, because when they do back out, it impedes people's extension. And the second is the size of the wires. Remember, many of these are done by orthopedic surgeons who like bigger and stronger, and better is that. If you use smaller wires, but use 2 of them and space the distance even further from the osteotomy with the second wire, it really presents very little problems with people leaning on these tension wires. So that's how I came up with that. And as a result, when people were sort of starting to say, well, we've got these anatomic plates and we've got, or these cancellous screws and all this and that, and I don't want to get into trouble with doing a fixation and having to take it out. Or people started to avoid osteotomy with different tricep splits or elevation on either side, but sometimes that's not so good with the complex articular fractures. I thought it would be worthwhile to look up my own personal experience, consecutive experience, and then report that. And so we don't see that many papers anymore by technique. And I remember a surgeon out in your way in California, Los Angeles, Joel Mata.
Yeah.
And Joel presented a series of 100 and something pelvic fractures done through his own extended anterior lateral approach. Yeah. And the results were rather spectacular. And he said, this is not and it was in Journal of Orthopedic Trauma a number of years ago, this is not a randomized prospective study. And it's a way to show if the technique is done, he sort of said correctly, yeah, but avoiding the pitfalls, and by an experienced person, this is what you would hope the procedure would do. And so that's the genesis of this paper.
That's great. I feel like that's a great discussion. You covered everything, I think, through the whole paper and pretty much all the questions I had.
Well, there's another paper that was probably 3 or 4 years ago from Edinburgh, the group there, and they looked at their experience with Electron fractures, comparing plates or osteotomies as well, plates versus a tension band.
Yeah.
And more secondary surgery was needed for tension band, but as I mentioned, it was done because pins were a problem or the tension wires were a problem, and that can be avoided. But they found when you had plates, and in some of the older age patients, they had wound breakdown. And if you have wound breakdown over an implant at that area, which is notorious for not healing so well, that presents a major problem. Okay.
Yeah.
So that's another thing. And the final thing is, if you have comminution, of course, that presents a different story. You don't want to have that with an osteotomy per se. But if you have a fracture and you have going to do a tension band, an Electron fracture, but the opposite cortex, meaning the articular side, is impacted or not intact, you have to be careful with a tension band because it will flex. In order for a tension band to work, by definition, the opposite cortex has to be intact or created with a bone graft or something else. Otherwise, you'll have a big bending moment, and that won't work.
Yeah. Are you still doing double wire for your tension band, or?
I've never changed.
Oh,
You know, that's from mid-70s.
Oh, if it works, it works.
Because it works.
Yeah, yeah. No, I mean, you kind of covered everything I wanted to talk about. So,
All right, that's the end of that video. So we'll move on to the next video. This article is results of linked convertible total elbow arthroplasty for the management of distal humeral fractures in the elderly. This is Dr. Adrian Wong talking with Dr. Strelzo.
Welcome to our Distal Humerus Fracture Journal Club. Today we'll be talking about the use of total elbow arthroplasty in the treatment of distal humerus fractures. My name is Dr. Adrian Huang, and I'm an upper extremity and trauma-trained surgeon here at the University of British Columbia. I am very excited to introduce our guest, Dr. Jason Strelzo. He is here to discuss his paper, Results of Linked Convertible Total Elbow Arthroplasty for the Management of Distal Humeral Fractures in the Elderly. Dr. Strelzo is an assistant professor at the University of Chicago, where he is a traumatologist and also specializing in upper extremity problems. When he did this study, he was at an institution that had a lot of extensive experience managing this in the entire gamut with respect to non-operative to operative. So it's going to be great to get his perspective on this topic. Dr. Strelzo, welcome, and thanks for being here with us. To start, why don't we just talk a little bit about the background of the paper, why you decided to go with its topic, and maybe a little bit about the current state of management of distal humerus fractures.
Yeah, no problem. I think you kind of hit the nail on the head there. I was fortunate enough to do my fellowship in London, Ontario, at a very specialized center where we saw and managed the whole gamut of distal humerus and upper extremity fractures. And as can be noted through the last probably 20 years of literature, that we've seen everything from treat it with a bag of bones technique with a cast or a splint and leave it alone and just let it kind of consolidate, all the way up to, as we're talking about today, total elbow arthroplasty. We wanted to try and add something to that literature, and I think we had a special opportunity, just given the numbers that we were treating and the numbers we were seeing, to be able to really study it. So I think from state of current management, I think if you look at some of the recent studies that have been published, you'll see that there's kind of this pendulum swung certainly towards management with total elbow arthroplasty, particularly in those patients that are elderly or older. And some of that, being drawn from some pretty small sample sizes and some small studies that suggest that maybe it was better or at least equivalent. And certainly, it can be a quote unquote simpler procedure if you do total elbow arthroplasty in your practice on a regular basis, but that doesn't necessarily mean that it is not fraught with complications and some very important caveats along the way. So I think that's where we are now, if I can summarize it for you.
That's awesome. No, that's a great summary. So, I mean, with respect to your paper, you mentioned that you're looking more so at the elderly population with the management of distal humerus with total elbow arthroplasty. So can you tell us a little bit about the characteristics of your patient populations, your patient selection, and then review some of the results and outcomes?
One thing that we really want to stress and highlight is that, this paper and the conclusions from the paper are in elderly patients. So on average, our patient population was 79 years old, plus or minus about 9 years. So for us, we wanted to have at least 2 years of follow-up. And so for us, it was really first-time injuries. These were unreconstructible fractures. Again, another important caveat.
In terms of your outcomes, understandably, there was a significant amount of your patients who unfortunately died just because of age. But the people you had back, they seem to be doing quite well.
Yeah, I mean, I think that's one of the positive takeaways of the study, certainly. If we look at some of the scores we used, patients did very well. And overall, their pain scores, again, almost, I think it was 70% of patients or 75% of patients had no pain whatsoever. And then, a PRE of 37 and quick dashes in the low 30s with the Mayo scores in the 90s. I think certainly these patients had very functional use of their elbow after their injuries, considering how bad these injuries really were. I think you point out a pretty important point, which is I think 50+ percent of the patients actually had died before the end of the study. So, being able to capture follow-up beyond that becomes difficult in this population. And I don't want to go so far as to say, distal humerus are definitely a fragility fracture that suggests that patients are in poor health, but certainly that is something that I think has been borne out in our paper and in a paper out of Toronto. They had similar findings looking at comparing a randomized trial of open reduction versus total elbow. I think they had over 50% mortality at 2 years as well. So,
yeah, and it's super interesting you said that, because even in your study, you noted that these patients, had some complications well outside the index surgery. They came back with periprosthetic fractures due to subsequent falls, just indicative maybe of their frailty. Can you talk a little bit about the complications that you had and maybe the rates and how they compare to kind of what's in the literature?
Yeah, I think one of the takeaways that we really wanted to highlight is that this is not a complication-free operation. I think, as we talked about earlier, this pendulum is swung that, total elbow is the preferred solution for distal humerus fractures. And I think for selected patients, it may be, but you have to appreciate that in our study and in a number of other studies, the complication rates in the low to mid 20s is at 2 years, right? Remember, this is only 2 years of follow-up, is very high. And in many other operations, we would not accept a 22% complication rate. That was the message we were hoping to kind of put forward. I think everyone is looking for the panacea of how to treat distal humerus fractures. And I think what we're trying to say is even in select patients with unreconstructible fracture patterns, this is not the magic potion that's suddenly going to allow these patients to be cured. But certainly, we published another paper on total elbow for rheumatoid arthritis, and we again had really high rates of ulnar nerve irritation, and in some cases, some ulnar nerve injuries that didn't recover. So again, not a perfect solution, but one that as we talked about for results, may provide some good outcomes.
In terms of those complications, as you mentioned, though, even though it's high, it seemed to be on par with essentially primary elbow arthroplasty. Would you agree with that?
Yeah, I think that's the interesting thing. You know, if you compare our complication rate compared to primary total elbow as well as ORAF for elbow fracture and distal humerus fracture, we're pretty much on par. So, you know, that 20%, although it's absurdly high, you have to put it in context and realize that, you know, if you're doing total elbow, these complications are going to happen. It certainly seems to fit well within the realm of the complication rates we see, both for distal humerus fractures treated with ORIF and for primary total elbow arthroplasty.
With ORIF for distal humerus fractures, there's arguably a higher rate of major reoperation. And I think you mentioned that in your paper. This could be one of those things where it's a one and done surgery for this elderly population. What is your take home? You know, is this somebody that should be done routinely, or is it something that should be done by a subspecialty surgeon?
People may disagree with this. I this should be done by a subspecialist that knows what they're doing, that does these at a relatively in a relatively proficient way at a relatively high volume. I think time and time again we've seen that surgeons that are high volume, that are trained and have the ability to do these operations at a very high level, do better, their results are better and their outcomes are better. And so, you know, given that this complication rate is 20+%, you want to keep it as low as 20+%.
So before we kind of sign off, I just wanted to maybe bring up one possibly contentious issue. In your paper, you specifically mentioned one patient who had poor patient-rated outcomes, however, really good objective outcomes. And his main complaint was that they were unable to carry heavy objects. Is somebody like that better for example, a hemiarthroplasty, which is not necessarily approved in the States, but I know that you and I both have experience of doing it, being from a Canadian center.
Yeah, I think that's a great question and a great topic. I obviously now practice in the States, having seen hemiarthroplasty and some of the results of hemiarthroplasty when I was in Canada and training in Canada. You know, I think it's a fascinating question about what the role of that implant is. Certainly for this patient, whose main concern was, hey, I can't lift heavy objects, I can't get back to those strength things that he wanted to do. That probably tells you that maybe the total elbow was not the right answer for that particular patient. I think there's probably a role for it. When you see some of the results from some of the small studies showing the results of hemiarthroplasty, they can be fantastic. And having done them in my fellowship and seen the results of them, wow, the recovery is fast, the patients get back to activities. And I think one of the things that's kind of nice is the bailout of that operation is a total elbow arthroplasty, right? And so would this patient in particular have been a candidate? Would he have been happier? Probably, because objectively, you know, he had scores that, you know, you or I would probably be happy with on a day-to-day basis.
Awesome. Well, thanks again for being here. Again, this is Dr. Jason Strezzo. He is an assistant professor at University of Chicago doing traumatology and upper limb problems. Yeah, thanks again for being here.
Thanks for having me, Adrian. Look forward to the discussion.
Great. So that concludes our
welcome to
last two videos. And we'll move on to the question and answer session now. So we'll hand over to Dr. Pennell to take it away and lead this discussion.
Thanks. Yeah, I got one. We can kind of pull all of the authors individually maybe, but somebody wants to know which method of fixation you prefer for an Electron osteotomy: tension band plate, cannulated screw, or tension band plate or cannulated screw. I think we know Dr. Jupiter's answer, but maybe we can start with Dr. Henley.
Sure. I think the question was tension band. I'm assuming wire or some plate or cannulated screw. We're basically at Harvard using 100% plates with a lag screw through the plate, usually out the anterior cortex, at least obliquely across the osteotomy site for compression in addition to the tension developed in the plate.
Yeah. How about Dr. O'Driscoll?
I was wondering, Dr. Hanley, if you've had any problems with wound healing, because although I designed a plate that can be used for that, I don't use plates for osteotomy anymore. I did for a little while, and I've gone back to tension band with wires. Certainly a screw or other techniques has some advantages too. But having said that, I did have a few patients with wound healing problems. I'm talking about erosion because of the plate, including one who eroded not through the wound, but about a centimeter adjacent to the wound because the wound was placed off the Electron. And I've seen some other surgeons' patients. So I was just wondering, have you been able to get around that problem and prevent it? Maybe it was because maybe I moved too early on those patients, perhaps.
Well, we move actually pretty early. The protocol, at least for my team, was to immobilize only for 48 hours. And usually we kept him in the hospital for that time, removed the splint, gave him a sling, told him to only use the sling for comfort, and start active flexion, gravity extension if there was an osteotomy. We'd let them actively extend if there was not an osteotomy, but we started all of them moving at 48 hours. In terms of soft tissues, I think it also depends on how much you undermine those soft tissue flaps in the proximal ulna. And if you're judicious, I only saw in my clinic, because it was 3 of us, we have 3 teams, a third, I guess, of all them done at Harborview. And I cannot recall in the last decade a soft tissue wound associated with a plate, as long as you're judicious about soft tissue management. See, I thought of one other thing to say, but it's I'm having a senior moment.
Well, I'm glad you mentioned about the soft tissue, because I can quite imagine that I might not have recognized that early, because it's a long time since I put a plate on the osteotomy, certainly at least 15 years. And so maybe I was elevating down onto the ulna, elevating flaps like at the humerus, and didn't even clue into that. So I really appreciate that.
A couple of things I've found out too is that if you elevate, including the periosteal submuscular envelope, we use actually a bovie right down the, I guess it's a posterior cortex, and release that and then close that over the plate. You can't do it really proximally, but you can close it in the proximal third. That really solves the soft tissue injury. And I should also add that if that closure is tight, I will do a little fasciotomy on both the extensor wad and the mobile wad, extensor and flexors, to allow that closure to be easier. And you can do that fasciotomy either externally underneath the soft tissue flap, then you have to elevate more, or internally along the periosteal muscular border. So usually I release it internally, meaning after you've elevated it, that frees it up. But if it's still tight, then I'll make either pie crusting or longer fasciotomies there to allow soft tissue closure over the plate. And we haven't seen problems, but again, I'm only seeing about a third of them. And we're doing quite a few at Harborview. Nobody seems to like to do these, so everything from a quarter of the landmass of the U.S. of these, I think, are coming to Harborview for the most part. We're a level 1 for a quarter of the landmass of the U.S. Geographically, which is pretty amazing.
Yeah.
And how about Dr. Strelzo?
I use the majority of the case. I use a plate, but in patients where their skin is poor, or I think they're going to have poor soft tissue coverage, I will typically go to the technique described by Adam Watts, where I use a tension band with suture only construct, and that seems to be working out for me now. 3 years, haven't had any problems, but I think the long-term implications of that technique haven't been borne out yet. But that's what I use in case I'm worried I'm just not going to get that coverage over the proximal aspect.
I think a little bit of a transition to another question on soft tissue, but somebody's asking about timing of fixation, and obviously probably dependent on the energy of injury. But if anyone wants to comment on, delayed versus acute fixation of these injuries.
Well, I might say there's really no urgency to do these. certainly not in the middle of the night. And talking about the older age patient, if they've landed on their elbow as a reason for causing the fracture, that's a traumatized skin by itself. So I think just like talking about post-op motion, as Dr. O'Driscoll pointed out, there's no urgency to move the patient because of soft tissue. So I think in this case, it's not, except an open fracture, of course, but otherwise, I don't see the need. One other point, if you make a straight dorsal incision and elevate flaps on either side, there's nothing wrong with that as long as you're careful. When you close, you have a dead space. And I didn't hear anybody talk about drains, but I think you can collect a hematoma there pretty easily. So I think it's wise to use a drain for 24, 48 hours.
Yeah, I agree with you, Jesse, because the arm is generally dependent in a sling-like position, and it's best we do use a small hemovac drain.
If I may just expand on that question really quickly as well, if we talk about specifically, like Dr. Jupiter had started talking about the elderly patients, you know, what is people's impressions on even how to treat them? Because, you know, Jason and I from the Hulk, you know, there's been some papers saying that for the elderly patient, non-operative intervention is probably reasonable. And then we've moved to this thing where, you know, total elbow arthroplasty is probably reasonable. And then the question then becomes, do you do, you know, primary total elbow arthroplasty for distal humerus in the elderly, or do you wait and then try to do a secondary salvage procedure? Because there is possibly some data now saying that a secondary total elbow, the outcomes may not be as good as a primary one. So I don't know, Jason, maybe we start with you, and then you know, ask the rest of the panel what they think about that. That's a huge question I've been kind of thinking about recently.
So yeah, it's a good question, Adrian. I think you know, your training is similar to mine, so I try and fix these at all costs as often as I can, and then deal with it if there's a problem later. I'm not someone who likes to just go with the initial primary total elbow. Whether that's a mistake or not, I don't know yet, but I'm sure I will find out. I'm fascinated to hear what the others think.
I want to get some clarification on how you define elderly. Some people say elderly.
That's a landmine. So I mean, maybe how would you define elderly?
Well, elderly is 1 year older than myself. Now I'm going to be
in perpetuity.
I'm going to be 75 in 3 or 4 months, and I have good bone, and I wouldn't want a total elbow. I'm pretty active, and so when it's not chronology, as you know, it's physiology. And your group in London and in South America and from Glasgow have published on bag of bones. And the original paper was in the early 70s by Brown and Morgan in England. And the results in the older age patient were spectacular. You need to have a reasonable alignment. If your epicondyles are mal-rotated and you can't get the trochlea olecranon orientation in the bag of bones, they probably won't do so well. But otherwise, remember, patients really don't need full motion. What they need is no pain and a good hand function and get to their mouth, especially if they have their other hand. So I think we put a lot of emphasis on motion, which is of course important, but some of these patients that I've treated with bag of bones over a number of years don't get full motion, but don't have pain if it works out well, and move functionally adequately.
Yeah, I would agree with you, Jesse. I've used that technique in unreconstructible fractures in people who I didn't think would tolerate surgery, or who are so osteoporotic that I thought arthroplasty was better, but that their overall condition could be addressed later. So you can get good outcomes, well, tolerable outcomes if they have a functional range of motion with bag of bones.
Yeah, I think I would add that I certainly agree with what's been said, but I would add that as I try to make the decisions, the factors that go into my mind are, is this patient, not elderly, but is this patient very low demand in a sense, or are they frail? And how urgent is it that I restore the function of the limb in this patient? There are patients for whom a trial period of seeing how they do is a horrible sentence for them, meaning that, you know, that's a real disability for them to go through that period, and you need to restore them. And so that would be another factor. And then the final is that doing elbow arthroplasty over many years and loving it and being involved in design for over 20 years, you know, I'm very aware of the potential problems. And, you know, one and done, you know, it's a good expression. For a number of years, I was thinking, well, that's probably what we'll do. But when you see some grave disasters after total elbow arthroplasty, it causes you to just hold back the enthusiasm a little bit. Now, having said that, and I think that total elbow arthroplasty is in a period where it's going to really change. So if you're near the beginning of your career, I think the indications will be very different at the other end of your career than they are right now. But I think we have to be careful about it.
Yeah, Dr. O'Driscoll, I agree with you. It's funny, Dr. King told me before I finished, he said, Adrian, just so you remember, a total elbow arthroplasty is a staged procedure by definition, you know, because there's always going to be a second revision down the line. He's kind of waiting for the other shoe to drop, so to speak.
Yeah.
Well, we have a couple minutes. I don't know, John, do you think we have time to see if Dr. O'Driscoll can share his slides on the capitellar shear components?
Yeah, that'd be great if you could.
I can, yeah, I'd be glad to try. So I'll just click, hopefully it works in this setup. I'll just click on share screen and go to that. I pulled it up here. So can you see my screen okay? It says common unit coronal shear.
Yes.
So what I'm going to do is I'm going to show the concept of how you do this first in a fracture that's just a common unit coronal shear. It's not a distal humerus fracture. So you can follow the sequence. And then I'm going to show the same thing in a common unit distal humerus fracture. So the first thing is you want to bring two screws, one, then the next, from the medial side across into the lateral side in this anterior portion. So here's the coronal shear over on your left, and we want the screws to come in close to the subchondral bone longitudinally along that fragment. Then you're going to bring in a couple of screws from lateral to medial through a plate. The plate itself isn't doing anything for the fracture, but the plate is an anchor point for the screws that go across, interdigitate with those first two, and then are anchored in the medial trochlea as well. Then you want to bring one or two screws from back to front, or as Dr. Henley said, you know, you may end up doing some burying them even front to back. So that's in a coronal shear fracture that's not a distal humerus fracture. Here we have now, and I just picked this one, there'd be other ones we could pick, but this is a distal humerus fracture with a coronal shear component. I picked this one as well because a key part is that the medial trochlea and medial epicondyle are not one fragment. Dr. Henley pointed out that that's a really critical thing. It's always the first thing I look at is the medial epicondyle, or the medial epicondyle and the medial trochlea one fragment. But here they're not. So we want to bring one screw and then a second screw from the medial side. Remember I said one at the epicondyle and one down low. In this case, I actually went up high and put another one later down low. So these come across from medial to lateral into the anterior part of the capitellum over here. And then we want to lock those in place with a couple of screws interdigitating from lateral to medial through the plate. So far, everything is in a plate. Then we want to fix with a couple from one or two from back to front. And because the medial trochlea was also, you know, a coronal fracture, I also added one medial on the medial side from back to front. Then there are, you know, some additional screws in place, but that's the concept. And otherwise, the technique is just as one would use for a distal humerus fracture of a different nature. And the principles being that all of that hardware in the distal segment, except for the added screws at the end from back to front, are contributing to supracondylar stability as well. That was a surgeon who was told that his fracture, 50-year-old surgeon, his fracture was not fixable and he would have to have an elbow replacement. But he did really well. He healed it very, very well and did well.
Actually, years ago, many years ago, we made a paper. We call that a triplane fracture.
Yeah.
And it's
That's right, Jesse.
Covers all three planes.
Yeah.
Good job, those.
It's not, it's not easy. It's very straightforward if you follow it step by step. It does require very precise placement of those first two screws into the coronal shear. And a targeting device is a good thing, but you can just drill across. And I drill right out the other side to make sure that I see where it comes out.
That's great. Thank you for sharing that with us. I think that's a great place to end, just given the time. I might just share my screen. I've got a couple more slides here real quick. Okay, so we just have a few take-home messages. We heard a lot of great points tonight. Dr. Henley spoke about some of the earlier failures in that series in the late 70s and early 80s and with 1/3 tubular plates. And this led them to using larger stock DCP plates, which allowed for early range of motion. And that's has really given rise to our modern constructs. Dr. O'Driscoll then talked about their principle-based parallel plating technique. And a few of these principles boiled down to what he described as a locking system of screws to, again, achieve the end of rigid fixation for early range of motion. Electron osteotomies, although easy in principle, the devil is really in the details when doing this procedure. And Dr. Jupiter took us through this technique and highlighted some of these details, including where to position the chevron, finishing the cut with an osteotome, and tips with respect to his tension band construct. Finally, Dr. Strelzo highlighted the benefits, but also the risks associated with total elbow arthroplasty. Low demand elderly patients with a non-reconstructible fracture seem ideal for this procedure, but they must be counseled on the limitations postoperatively, as well as a complication rate that we were quoting around 20%. So I want to just publicize the dates for our upcoming Journal Club sessions. We're going to into August and September and October. The topics are listed there. There's no session in July. We're taking a month off in the summer. You can access the recording, should be available within the next 24 hours on the YouTube channel. There's a bunch of great videos there, including all the old webinar journal clubs. And I just want to thank everyone attending. I want to thank especially the moderators and the authors. And you'll see the questionnaire that just popped up there. Please fill that out and join us for the next webinars. Thank you again to everyone for attending.